Pathophysiology of Schizophrenia, and Pharmacology of Kaplaida. Schizophrenia is a lifelong debilitating neuropsychiatric disease affecting nearly 1 in every 100 people. It is associated with a markedly reduced life expectancy of 20 to 30 years less than that of the general population. The symptoms of schizophrenia are generally divided into several groups, known as positive, negative, and cognitive symptoms. The positive symptoms of schizophrenia can manifest as delusions, hallucinations, agitation, and distorted or exaggerated language and communication. Disorganizations in speech, thought, and behavior, and even a catatonic state may also be observed. These positive symptoms may be conspicuous to observers and often result in hospitalization or entry into the legal system. The negative symptoms of schizophrenia include emotional and social withdrawal, anhedonia, deficits in attention, abstract thinking, and spontaneity, as well as blunted affect. Cognitive symptoms of schizophrenia include difficulties with attention, learning, and memory, and engaging in goal-directed behavior. The classical dopamine hypothesis of schizophrenia suggests that hyperactive mesolimbic dopamine could drive the positive symptoms of schizophrenia by overstimulating D2 receptors in brain regions including the basal ganglia and nucleus accumbens. A key piece of support for the role of hyperactive D2 neurons in psychosis, or delusions and hallucinations, is that D2 receptor binding and attenuation of D2 receptor signaling is a fundamental property of nearly all antipsychotics. More recent analyses suggest that the nigrostriatal dopaminergic pathway may contribute to the positive symptoms of schizophrenia. The associative striatum receives dopaminergic inputs from the substantia nigra and may show elevated presynaptic dopamine function in schizophrenia, reflecting increased synaptic dopamine concentrations, synthesis capacity, and release. Striatal dopamine dysfunction is thought to dysregulate dopamine function in the prefrontal cortex, or PFC, directly or indirectly, while hyperactivation of striatal D2 is thought to underlie the positive symptoms of schizophrenia. It has also been suggested that hypoactivity of other types of dopamine receptors in the PFC may underlie schizophrenia's negative and cognitive symptoms. The PFC is thought to control executive and emotional functions. Insufficient activation of PFC dopamine receptive regions can often lead to negative symptoms, cognitive deficits, and altered emotional functioning in schizophrenia. The serotonin hypothesis of schizophrenia emerged following evidence that psychotogenic substances can affect serotonin systems. Whereas their D2 antagonism defined the classical antipsychotics, atypical antipsychotics block not only D2, but also 5-HT2A serotonin receptors. Serotonin projects from cell bodies in the raphe to various dopamine receptor-rich brain regions, including the nucleus accumbens and PFC. 5-HT2A function is suspected to be dysregulated in people with schizophrenia, and it has been suggested 5-HT2A antagonism may directly exert antipsychotic effects. Other serotonin receptor types, such as 5-HT1A receptors, may also be dysregulated in schizophrenia. The glutamate hypothesis of schizophrenia postulates that a deficiency in glutamate receptor function also contributes to this disorder. In schizophrenia, hypofunction of NMDA glutamate receptors on GABA intraneurons in the PFC may reduce GABA intraneuron responsiveness to stimulation by primary glutamate neurons. Reduced GABA release may then disinhibit secondary cortical glutamate neurons and drive downstream disturbances in the dopamine function that underlies the positive and negative symptoms of schizophrenia. Dopamine may, in turn, modulate cortical glutamate receptor function through dopamine receptors. In addition to NMDA receptors, dysregulation of AMPA glutamate receptors has also been implicated in schizophrenia. Schizophrenia appears to involve multiple neurotransmitter systems that contribute to heterogeneity in symptoms of the disorder. It has been proposed that interactions between multiple neurotransmitter systems should be considered in the pharmacological approaches used to treat schizophrenia's core pathology. We hope you found our discussion of the hypothetical neurocircuitry of schizophrenia to be informative and thought-provoking. Now we will take a few moments to discuss Caplyta, also known as lumateperone, which is an atypical antipsychotic for treatment of schizophrenia in adults. Like all antipsychotics, the exact mechanism of action of Caplyta is unknown. The efficacy of Caplyta could be mediated through a combination of antagonist activity at central serotonin 5-HT2A receptors and postsynaptic antagonist activity at central dopamine D2 receptors. Caplyta is indicated for the treatment of schizophrenia in adults. Elderly patients with dementia-related psychosis treated with antipsychotic drugs are at an increased risk of death. Caplyta is not approved for the treatment of patients with dementia-related psychosis. The clinical relevance of Caplyta binding is unknown. Caplyta simultaneously binds to serotonin 5-HT2A, dopamine D2 and D1 receptors, and the serotonin reuptake transporters, or SERT. In preclinical and clinical studies, Caplyta had an approximately 60-fold separation in its receptor binding affinity for 5-HT2A over D2. Additionally, Caplyta does not appear to show significant binding for off-target receptors, such as the histamine 1 receptor or muscarinic acetylcholine receptors. Caplyta demonstrates an approximately 60-fold separation in its binding affinity for 5-HT2A over D2 receptors, where 5-HT2A receptor occupancy approaches saturation at a D2 receptor occupancy of about 40%. Elevated levels of dopamine D2 receptor occupancy are known to be associated with increases in extrapyramidal symptoms and prolactin. Caplyta also binds to the serotonin reuptake transporters. In addition, Caplyta is believed to bind D1, although with a slightly lower affinity than D2. The binding of Caplyta to D1 receptors may contribute to indirect activation of the AMPA and NMDA receptors. Caplyta is an antipsychotic drug that shows approximately 60-fold selectivity for 5-HT2A over D2, moderate binding affinity for D1 and SERT, and low binding affinity for off-target histaminergic and muscarinic receptors. Caplyta, lumateperone, is indicated for the treatment of schizophrenia in adults. Important safety information. Boxed warning. Elderly patients with dementia-related psychosis treated with antipsychotic drugs are at an increased risk of death. Caplyta is not approved for the treatment of patients with dementia-related psychosis. Contraindications. Caplyta is contraindicated in patients with known hypersensitivity to lumateperone or any components of Caplyta. Reactions have included pruritus, rash, for example, allergic dermatitis, papular rash, and generalized rash, and urticaria. Warnings and precautions. Antipsychotic drugs have been reported to cause cerebrovascular adverse reactions in elderly patients with dementia-related psychosis, including stroke and transient ischemic attack. See boxed warning. Neuroleptic malignant syndrome, which is a potentially fatal reaction. Signs and symptoms include hyperpyrexia, muscle rigidity, delirium, autonomic instability, elevated creatinine phosphokinase, myoglobinuria and/or rhabdomyolysis, and acute renal failure. Manage with immediate discontinuation of Caplyta and provide intensive symptomatic treatment and monitoring. Tardive dyskinesia, a syndrome of potentially irreversible dyskinetic and involuntary movements which may increase as the duration of treatment and total cumulative dose increases. The syndrome can develop after a relatively brief treatment period, even at low doses. It may also occur after discontinuation of treatment. Given these considerations, Caplyta should be prescribed in a manner most likely to reduce the risk of tardive dyskinesia. Discontinue Caplyta if clinically appropriate. Metabolic changes, including hyperglycemia, diabetes mellitus, dyslipidemia, and weight gain. Hyperglycemia, in some cases extreme and associated with ketoacidosis, hyperosmolar coma, or death, has been reported in patients treated with antipsychotics. Measure weight and assess fasting plasma glucose and lipids when initiating Caplyta, and monitor periodically during long-term treatment. Leukopenia, neutropenia, and agranulocytosis, including fatal cases. Perform complete blood counts in patients with pre-existing low white blood cell count, WBC, or history of leukopenia or neutropenia. Discontinue Caplyta if clinically significant decline in WBC occurs in absence of other causative factors. Orthostatic hypotension and syncope. Monitor heart rate and blood pressure and warn patients with known cardiovascular or cerebrovascular disease. Orthostatic vital signs should be monitored in patients who are vulnerable to hypotension. Falls. Caplyta may cause somnolence, postural hypotension, and motor and/or sensory instability, which may lead to falls and consequently fractures and other injuries. Assess patients for risk when using Caplyta. Seizures. Use Caplyta cautiously in patients with a history of seizures or with conditions that lower seizure threshold. Potential for cognitive and motor impairment. Advise patients to use caution when operating machinery or motor vehicles until they know how Caplyta affects them. Body temperature dysregulation. Use Caplyta with caution in patients who may experience conditions that may increase core body temperature, such as strenuous exercise, extreme heat, dehydration, or concomitant anticholinergics. Dysphagia. Use Caplyta with caution in patients at risk for aspiration. Drug interactions. Avoid concomitant use with CYP3A4 inducers, moderate or strong CYP3A4 inhibitors, and UGT inhibitors. Special populations. Neonates exposed to antipsychotic drugs during the third trimester of pregnancy are at risk for extrapyramidal and/or withdrawal symptoms following delivery. Breastfeeding is not recommended. Avoid use in patients with moderate or severe hepatic impairment. Adverse reactions. The most common adverse reactions in clinical trials with Caplyta versus placebo were somnolence, sedation, 24% versus 10%, and dry mouth, 6% versus 2%. Please see accompanying full prescribing information, including boxed warning.